We're ready, Anna.
So we will wait a little bit to let the assistants, the attendees come in. Good morning to everyone who is following us from Latin America and the Caribbean. Good afternoon for everyone who is following us from Europe. I would like to extend our warm welcome to everyone who is attending the last of the 6 key lecture sessions of the EU-LAC Foundation and the University of Hamburg. This session will be dedicated to the health systems in Latin America and Europe, and it will conclude this series on the consequences that the COVID-19 pandemic has had on different aspects of the lives of our societies. We talked in the previous sessions, for example, about the education sector. We talked about the labor markets. We talked about gender relations. We talked about cities. And we also were talking about the situation of migrants in both of our continents. The keynote lectures were always very interesting and inspiring, and in some ways they were always complementary and entered into dialogue with one another. So I hope we can achieve something similar in this last session. I would like to explain to everyone who is following us on the Zoom platform that we have an interpretation service available between English and Spanish. In order to listen to the session in Spanish or in English, you can just go to the interpretation button and then choose the channel in which you would like to follow us, either in English or in Spanish or just in live without any form of interpretation. And now I will pass the word to my colleague, Dr. Gilberto Rescha, who will present the first of our 2 panelists for today.
Igual de mi parte, buenos días y buenas tardes a todos. Me da mucho gusto poder darle la bienvenida a nuestra primera ponente hoy, a Paula Cafarena Barquencilla, que es doctora en Historia por la PUC, la Pontificia Universidad Católica de Chile. Sus investigaciones se han centrado en la historia de la salud pública en Chile, especialmente tomando en cuenta la relación entre Estado, salud y sociedad, y en el estudio de las epidemias. Ella es autora del libro Viruela y vacuna, difusión y circulación de una práctica médica. Ha publicado artículos académicos sobre historia de la salud y sobre el periodo de independencia en Chile y Hispanoamérica. Igual ha impartido clases de historia de Chile y América durante el siglo XIX, así como seminarios de investigación en la Universidad Finisterre. Actualmente es investigadora y directora del CIDOC, el Centro de Investigación y Documentación, y profesora de la Escuela de Historia de la Universidad Finisterre en Santiago de Chile. Nos da mucho gusto tenerte con nosotras y esperamos tu ponencia.
Muchísimas gracias. Bueno, antes que todo quiero agradecer la invitación, la posibilidad de compartir con todos ustedes mis investigaciones y también los análisis que se pueden hacer a partir de la pandemia que estamos viviendo actualmente. Voy a compartir la pantalla para comenzar con la presentación. Bueno, el objetivo de esta presentación es contextualizar un poco a partir de lo que estamos viviendo las epidemias en términos históricos, ofrecer una mirada desde la historia, ver cómo las sociedades pasadas han enfrentado las epidemias, cuáles han sido las estrategias, cuáles han sido los tratamientos que se han puesto en marcha, y también cómo han habido algunos que han sido los preponderantes, ¿no es cierto?, y que han permitido que nuestras sociedades pasadas enfrenten estas situaciones de epidemia. Y eso nos va a permitir también, a modo de conclusión, identificar cuáles son los grandes desafíos que se han enfrentado históricamente. Con esta presentación creo que el gran objetivo es poner en conocimiento de todos algunas herramientas que puede ofrecer la historia para un análisis también que podemos hacer desde el presente. Lo primero, para comenzar, comentar algunas enfermedades que son de una u otra manera aquellas más características, aquellas que más conocemos, y que han marcado este paso o esta historia, ¿no es cierto?, estos hitos en la historia de la salud y de las epidemias. En primer lugar, podemos mencionar la viruela, una enfermedad que si bien tiene una larga data, hay registros muy antiguos de epidemias de viruela antes de Cristo, es una enfermedad que tuvo un recrudecimiento muy importante durante el siglo XVIII, y su difusión justamente se vincula a la conquista de nuevos territorios y también a la intensificación de nuevas rutas comerciales, sobre todo a partir del siglo XVIII, de la revolución industrial y de la necesidad de una mayor circulación en términos de productos que circulan por estas rutas comerciales, y también la circulación de personas a partir del descubrimiento de nuevos territorios y de la necesidad de comercio que también se empezó a desarrollar durante ese periodo. Entonces, otra enfermedad importante que nosotros podemos identificar también como dentro de estos hitos o este contexto que me interesa entregar respecto a la situación sanitaria desde la historia, tiene que ver con la escarlatina, que si bien es una enfermedad que tal vez nosotros identificamos hoy como algo que puede ocurrir, que no es una enfermedad asociada a un nivel alto de mortalidad, en términos históricos tiene un peso importante. Aquí yo menciono unos datos de escarlatina para el caso de Chile propiamente tal, 1832, 1842 y 1929, que son epidemias que yo he tenido la oportunidad de estudiar con más detalle, y que nos muestran, y esto también es posible mencionarlo a nivel más general, que la incidencia de la escarlatina tiene mucho que ver, o repuntó, con los procesos de urbanización que en general carecían en un inicio de condiciones mínimas de higiene y de salubridad en general. Por lo tanto, también acá en esta historia de las epidemias nos encontramos con algunas enfermedades que en su versión más letal, ¿no es cierto?, van a causar bastantes estragos en la población, sobre todo del siglo XIX y también del siglo XX. En el caso de la escarlatina hay un recrudecimiento a nivel mundial y se habla de un periodo pandémico de escarlatina más o menos entre los años 20 del siglo XIX y hasta inicios del siglo XX. Por lo tanto, también ahí hay un segundo hito relevante. Luego, una enfermedad que sin duda está mucho más arraigada en el imaginario de todos, que tiene que ver con el cólera, donde también en el caso de Chile se registró una de las epidemias más mortíferas entre 1886 y 1887, pero de todas maneras también corresponde a este ciclo de difusión del cólera y de recrudecimiento también de la enfermedad a nivel general. En el caso, por ejemplo, de algunas ciudades, se llegó a perder cerca del 5% de la población, y en general se asoció a el cólera una enfermedad vinculada a la pobreza, o enfermedad de la pobreza, que se tendía a llamar así. El caso del cólera se hizo muy evidente que mientras menos condiciones de higiene existiesen, más posibilidad de enfermar. Y eso tenía mucho que ver, ¿no es cierto? Bueno, hoy ya después de los estudios que se hicieron posteriormente, sabemos, ¿no es cierto?, que tenía que ver con la ingesta de aguas contaminadas y también por las condiciones de hacinamiento que vivían muchas personas que vivían cerca de acequias, de lugares donde morían animales y eso infectaba las aguas, etc. Por lo tanto, también esta enfermedad se asoció con las condiciones socioeconómicas de la población. Y los médicos de aquella época, si bien no conocían en un inicio la razón científica de la enfermedad, sí identificaban estas relaciones que fueron importantes igualmente para combatir. Y finalmente también el caso de la influenza, que sin duda en el imaginario colectivo es una de las epidemias que más presente está y que a raíz del COVID-19 apareció mucho, y en términos de establecer también comparaciones. ¿Qué pasó con la influenza en 1918? ¿Cuáles son las características similares que se pueden identificar con la situación de pandemia actual? Yo siempre puntualizo que creo que cada pandemia o cada epidemia debe ser estudiada en sus propios contextos, y porque justamente eso es lo que va cambiando, ¿no es cierto? Es muy distinto pensar en una epidemia de influenza en 1918 que en el año 2021, básicamente porque los contextos, ¿no es cierto?, han variado profundamente, y eso es un elemento central para poder entender efectivamente estos procesos. En el caso de la influenza, hay dos elementos que son importantes de rescatar para poder entender cómo se fue analizando y también procesando esta enfermedad. Lo primero es la aparición del papel de la prensa. Es una de las primeras epidemias que recibe mucha atención de parte de la prensa, tanto en América Latina como en países europeos. Y se difunden noticias respecto a esta gripe a través de esos medios de comunicación. Hacia 1820 eso era muchísimo más limitado, ¿no es cierto? Yo he realizado estudios de prensa, sobre todo para el caso chileno, y si bien se usaba la prensa para dar cierta información, es completamente distinto en términos como publicitarios de lo que va a ocurrir en un periodo posterior. Y por otra parte, una situación muy relevante respecto a la influenza es que esta epidemia y esta pandemia ocurre en un periodo donde había una confianza muy fuerte respecto a los progresos científicos que se habían logrado, respecto al conocimiento y el tratamiento de las enfermedades. Sin embargo, a pesar de todos esos progresos, la influenza viene a mostrar que a pesar de todo eso, ¿no es cierto?, igualmente llega una epidemia que pone en jaque a las sociedades enteras. Por lo tanto, se genera un quiebre con esa épica del progreso médico que se había venido desarrollando, sobre todo desde fines del siglo XIX, con la implementación y la difusión de la teoría de los gérmenes, la aparición de antibióticos, ¿no es cierto?, que habían permitido un mayor control de las enfermedades. Por lo tanto, también hay que mirar esta pandemia en esa clave, ¿cierto? Cómo se fueron poniendo en jaque estas narrativas respecto al progreso. Ahora, una pregunta relevante que podemos hacernos para contextualizar la enfermedad en términos históricos tiene que ver con qué hicieron las sociedades pasadas para controlar las epidemias. Cuando decimos las sociedades pasadas, sin duda es un concepto muy amplio, pero de todos modos nos permite ver que justamente hay una multiplicidad de tratamientos que se van poniendo en marcha y que van tomando las diferentes autoridades para combatir las enfermedades. Dependiendo de las épocas, dependiendo de los contextos, vamos a ver que se usan medidas de aislamiento de la población que siempre van a ser controvertidas y su efectividad limitada. Hay muchos testimonios que muestran, por ejemplo, en el caso de la viruela, cuando tratan de cerrar ciudades, que eso pone en jaque la posibilidad, por ejemplo, de alimentación de la población al no permitir que ingresen alimentos, la dificultad también que se empieza a registrar respecto a que las madres dejen a sus hijos enfermos de viruela lejos de sus casas, en hospitales destinados para ello. Por lo tanto, siempre van a ser medidas controvertidas. la vacunación, que ya aparece, ¿no es cierto?, a fines del siglo XVIII, específicamente contra la viruela, medicinas de distinto tipo, homeopatía, que también va a ser un tratamiento que circule durante el periodo, ¿no es cierto? Incluso la presencia de sangrías, la presencia de medidas de higiene. Lo que quiero mostrar acá es que existe una multiplicidad de tratamientos que muchas veces van a funcionar de manera conjunta, y también que nos muestran que a pesar de las limitaciones, las sociedades pasadas siempre han tenido formas, estrategias de enfrentar las epidemias. No han sido sociedades estáticas, a pesar de que muchas veces los tratamientos no eran tan efectivos como ellos hubiesen querido. Ahora bien, existen tal vez cuando uno como trata de sintetizar y de buscar cuáles son los pesos históricos que han tenido como mayor relevancia, existen dos tratamientos que en definitiva han ido moldeando la manera en que se enfrenta la enfermedad. Por una parte, todo aquello que tiene que ver con las corrientes higienistas y con la implementación de medidas de higiene para frenar el avance de la enfermedad. Y aquí, sobre todo para el caso de América Latina, se empezó ya desde el siglo XIX a manifestar una diferencia muy notoria respecto a la vida rural en el campo y la vida urbana, en el sentido que se identificó que la urbanización traía consigo un mayor contagio de determinadas enfermedades, como era el caso que les mencionaba al inicio de la escarlatina. Y quienes vivían en el campo, mencionaban por ejemplo los médicos de la época, gozaban de aire más limpio, más puro, mayor espacio, y eso permitía un menor contagio. Por lo tanto, la urbanización estuvo asociada también a la necesidad de implementar medidas de higiene para, por ejemplo, evitar que las personas viviesen en condiciones de hacinamiento. Hay muchos relatos, ¿no es cierto?, que muestran que las personas vivían en habitaciones sin ventilación. Las ciudades, sobre todo en América Latina, demoraron bastante tiempo en tener buenos sistemas de alcantarillado que permitiesen entonces mejorar las situaciones de higiene urbana y de higiene habitacional. Y eso posteriormente también se va a vincular o va a derivar también en la solicitud que se le empieza a hacer a la población de las medidas de higiene personal, que es algo que sin duda podemos ver hoy actualmente a raíz de la pandemia que vivimos, ¿no es cierto?, cómo se enfatiza en la necesidad de estas medidas de higiene y de autocuidado, ¿no es cierto?, que tienen que ver con el lavado de manos, la higienización en general, el uso también de mascarillas, etc. Por lo tanto, el higienismo va a ser, o ha sido históricamente fundamental en el control de las enfermedades, y las sociedades pasadas también han recurrido a este tipo de tratamiento. Y por otra parte, la importancia de la vacunación. Si bien la vacunación empezamos nosotros como en términos históricos, la primera vacuna que es contra la viruela, la que tradicionalmente se asocia al descubrimiento de Edward Jenner en 1796, va a ser una medida que una vez puesta en marcha nunca más dejó de funcionar, ¿cierto? Es una medida que sin duda sabemos que finalmente logró erradicar la viruela, y que de esa manera hoy nosotros no contamos con la enfermedad. La poliomielitis, si bien no ha sido erradicada, es una enfermedad que en buena parte de los países hoy está controlada. Ahora, ¿qué me interesa destacar de la vacunación en términos más globales, y que también fueron reflexiones que aparecieron en las sociedades pasadas? Por una parte, la necesidad de que la vacunación debe ser universal para que funcione. Cuando uno lee los testimonios de médicos durante el siglo XIX, sobre todo, y fines del XVIII, aparece muy clara la necesidad de que todos deben vacunarse para que de esa manera se consiga el control de la viruela, por ejemplo, en ese momento. Por lo tanto, los discursos apuntan siempre a la necesidad de expandir la vacunación. Hubo una conciencia muy temprana de que no sacaban nada con vacunar a un grupo reducido de población, sino que lo que necesitaban era aumentar la cobertura para que de esa manera se lograra el control de la enfermedad. Y por otra parte, la vacunación también puso como en primer plano la idea de la prevención de una enfermedad. Y eso va a ser muy relevante en el control de las enfermedades, porque durante o hasta inicios del siglo XIX, en general, la idea era atacar la enfermedad cuando aparecía. O sea, si había una epidemia de viruela, se enfrentaba. Sin embargo, con la vacunación hay un giro relevante donde ya no está puesto en la curación, sino que va a estar puesto en la prevención. Y en ese sentido vamos a tener y vamos a poder observar en diferentes partes en Europa o en América que se desarrollan campañas de vacunación, aunque no hay epidemias de viruela, y esas campañas van a estar estrechamente vinculadas con programas de salud pública, muchas veces incipientes, pero que van a tener como foco la prevención. ¿Qué nos dice entonces la historia de la salud respecto a las epidemias y a cómo enfrentarlas? Acá hay tres aspectos que a mí me gustaría destacar y que resumen un poco o vienen a recoger aquellas ideas que he estado planteando anteriormente. Por una parte, la historia de la salud nos muestra que la intensificación de rutas comerciales, la movilidad de personas y los mismos procesos de urbanización son parte estructural de las sociedades, y eso viene también, o en esa misma circulación aparece la enfermedad. Probablemente mientras existan esos factores, ¿no es cierto?, la enfermedad siempre va a seguir formando parte de lo que es o de lo que consiste finalmente nuestra sociedad. De esa manera resulta importante puntualizarlo también y mirarlo en esa perspectiva histórica, porque a pesar de que hoy, siglo XXI, ¿no es cierto?, tenemos un control muy importante de una amplia gama de enfermedades, mientras existan estos elementos, por supuesto que van a seguir apareciendo enfermedades, y de esa manera pareciese que la enfermedad, ¿no es cierto?, sobre todo la enfermedad contagiosa, ¿no es cierto?, tenemos que considerarla como parte estructural de estas condiciones que les menciono. Ahora, ¿qué nos dice también un poco el análisis que hacemos desde la historia de la salud? En primera parte, que finalmente analizar las epidemias o las pandemias desde una perspectiva histórica nos muestra el peso que tiene lo multidimensional. Cuando nosotros estudiamos hacia atrás las epidemias, nos damos cuenta y uno puede ver con mucho más claridad cómo son un conjunto de factores los que van determinando el significado que tiene cada epidemia y en cada sociedad. Son factores políticos, económicos, sociales, culturales, etc. Las epidemias nunca son solo un virus o una bacteria. O sea, las epidemias tienen su dimensión biológica, pero tienen también esa dimensión política, económica, cultural, que en realidad es imposible que se pueda disgregar, es imposible que podamos separar esos elementos. Por otra parte, la relevancia de los contextos. Cada epidemia debe ser estudiada en sus contextos, porque no es lo mismo, hacia el siglo XIX lo decían como no es lo mismo una epidemia en el campo que una epidemia en la ciudad, pero hoy sabemos que no es lo mismo una epidemia en países de altos ingresos como en países de bajos o medianos ingresos. Por lo tanto, y también en contextos políticos diferentes, etc. Y finalmente, otro de los factores importantes tiene que ver con la salud pública, ya que probablemente, y creo, al menos puedo quizás plantearlo con mayor claridad para el caso de Chile, si una cosa ha mostrado el COVID-19 es la relevancia que tiene la salud pública en el control de la enfermedad. Acá la importancia me refiero a la acción estatal, a la coordinación estatal y a las diferentes instituciones que permitan finalmente un control de la enfermedad y no a nivel país, no solamente, ¿no es cierto?, a partir de los esfuerzos individuales que cada persona pueda hacer. Eso quería comentarles hoy, espero que haya quedado claro, si no, de todas maneras, cualquier pregunta podemos conversarla después. Muchas gracias.
Bueno, muchas gracias, Paula. Okay, so now I'm very glad to welcome Sabrina Montante. Sabrina Montante is a senior EU policy advisor at Istituto Superiore di Sanità since 2016. And she also belongs to the coordinating team of the EU project TO REACH. And I think today she's going to talk just about this project or about a part of this project. And Sabrina Montante has been head of EU affairs and a lecturer in EU health policy and programs at the Università Cattolica del Sacro Cuore since January 2014. And she has worked for over 10 years on public policy, multi-level governance and management experience in the health sector. So far, she worked with diverse international and EU organizations, research entities, national and regional offices. Sabrina earned a Master of Laws degree from University of Bologna and a project management graduate certificate from Boston University. And currently she's studying public health at the London School of Hygiene and Tropical Medicine. Well, again, thank you for giving a talk today. And the floor is open. Thanks.
Hello, can you hear me well? Okay, thank you. Thank you very much for your invitation. So I will try to share my slides. I don't know if you, I should immediately make my presentation, or you should wait. We should wait for some questions for Paula. I don't know.
No, the discussion will take part after the presentation.
Okay. Okay, sounds good. Okay, let me just open this presentation. No, that's not this one. Or let me just give it the right one. Okay, can you see it? Perfect. So thank you very much for your presentation. Thanks also for your invitation. Thanks for the presentation indeed. You perfectly summarized the activity in which I'm involved for the moment. So today I am here on behalf of the National Institute of Health of Italy, but I would say also of the coordinating team indeed of the project TO REACH. I will make a short presentation, or I mean, the shorter as possible of the project, and I will also mention the work that the project is doing at European level to build the future partnership on transforming health and care systems. So I would start by saying, setting the context of the work we are doing at European level. I would say also at the international level, because the work of TO REACH has indeed involved also the countries outside of Europe. And the idea of the partnership will be also to collaborate with countries outside of Europe. Of course, this is starting in Europe, but the perspective is broad and open, especially because we are talking about health systems and challenges faced by health systems, which we can say are quite the same at European, but also at a global level. And this was even more highlighted by the current pandemic that we are living. In particular, of course, in Europe, health systems also share the same values, and of course, we have different programs funding research, innovation, project that try really to have a common priorities on biomedical research. We do have some research on public health, but it's still fragmented. And in particular on health and care systems, there have been some projects done at European level, but it seems necessary to make an effort to really work better together. Of course, in Europe, we share a common context in terms of legal, financial, and policy context, which of course make even more necessary some efforts really to come with evidence that help to build a sustainable policy in this regard. And these common challenges and context provide potential for shared learning. COVID-19, I don't need, to say, I think it's clear to everybody, as I highlighted, pre-existing challenges already faced in Europe and abroad in health systems. The project To Reach was pre-existing and was identifying challenges that have been just more highlighted by the pandemic. The complexity, interconnectedness, and of health and care systems and are showing us how difficult it is to introduce change, and even more when introduced how it's possible to adequately manage this change in a very rapid and evolving environment. And this was exactly the focus of To Reach, focusing really on how to introduce innovation in health and care systems, how to make sure that they are sustainable, effective, comprehensive, equal, and resilient, and how to do it through the introduction of innovation and making sure this innovation can be implemented across different countries and settings, looking at the context. This journey started back in 2013. When was published an article in Lancet called Health Systems and Policy Research in Europe, Horizon 2020, when high-level researchers in Europe, part of different scientific community, well-known also at a global level, decided really to come together to write an article which was really show how much focus was given to biomedical research at European level in the program at European level, but how still was given too little space to research, innovation, and health systems and services, and how much this was necessary because they are the translator of the innovation happening in the biomedical research to make sure that this can reach the practice and the citizens and patients. And this article that was published in 2013 reached the attention of the European Commission. And there were some meetings, some, of course, advocacy to make sure that the Commission and member states working on the future, at that time was the future Horizon 2020, was actually introducing it in its work program, a specific action looking at a strategic research agenda, identifying the priorities for more research in this field. When we talk about health services and system research, we have to clarify what we're talking about because it's not necessarily clear to everybody. We know that it's a multidisciplinary field of health research that is needed to better translate biomedical innovation to end users, therefore citizens and patients. And it's including in different expertise is looking at system research at micro, meso, macro level. And indeed, as you can see in this slide, is looking at really different field of research, different competence and skill, indeed showing the multidisciplinarity of the field from delivery science, improvement science, operations research, implementation science, management science. So it's a very large field of research. The goal of To Reach, indeed, was in this regard to prepare a joint research innovation program aimed at producing research evidence supporting, indeed, this field of research, health and care systems and health and care services and systems as such, to become more resilient, effective, equitable, accessible, sustainable, comprehensive. And I have to say that To Reach has created a real movement in this field in Europe. It was much more than just a project. It was really a movement, an advocacy movement, really, in Europe to make sure that concepts and were better clarified clarified, vocabulary was also better clarified, and that the efforts made by all actors were going to the same directions. And it was a coordination and support action. I say was because started on the 1st of December 2016, but ended already on the 31st of May 2021. Actually was extended twice by the European Commission, so it lasted 5 years. It's not a research project, and indeed it was really a project that had a double goal. On one hand, build a strategic research agenda, and on the other hand, build actually the program, a future joint action, future program for future research at European level, in which there were the efforts of countries and Commission had to come together. Future joint program is beneficial, will be beneficial to for three perspectives. Policy perspective, because we need also to build evidence that can be better translated to decision makers to take the right direction. Funding perspective, because we have limited resources in Europe and not only on research in general, and we need to avoid duplication. And scientific perspective, because we can best incorporate this delivery element into translational research design. And the strategic research agenda developed by the To Reach project was composed mainly by two important parts. So the focus, the scope that then was supposed and is supposed to inform this joint initiative was really focusing on two important parts. On one hand, the need to identify new solutions able to respond to rising challenges, really to identify what priorities we should focus on. And this other part is really, once we know what we should focus on, what should be the priorities, how we can make sure that this the innovation and all practices, best practices happening in that specific field area can be implemented and transferred effectively in other settings. This was the consortium. It's important to say that outside of Europe, we had the participation of the USA and Canada, and we also had Israel with us. For the USA, let me see, we had the Agency for Healthcare Research and Quality in the United States. Then we had the Israeli Ministry of Health. And then we had the Institute of Health Services and Policy Research in Canada. And with regards to the other countries, all of them European countries, we had mainly ministries or institutions, public health institutions on funding bodies, funding research in Europe. But we also had representatives of research organizations from the Netherlands, from Latvia, Malta, Romania, Finland, Italy, but also we had international organizations like European Observatory on Health Systems and Policies, which is WHO basically, and European Health Management Association and European Public Health Association. So as I said, health systems are translators of innovation. So biomedical innovations for both prevention and treatment, from basic science to clinical science, need to be delivered to our citizens who represent ultimate beneficiaries of our work. And this happens through our systems. But we know we need also to innovate the mechanism. So we immediately identified one gap that was existing at the European level, and not only at European level, which was the implementation of innovation, which is still a constant challenge. There is evidence of widespread and persistent gap between evidence and practice in healthcare. I posted here some interesting article that you can also use for follow-up to this lecture. There are reasons for variation that are not well understood. Variation not negative or harmful, but we need to understand why they happen and what levels of the levels of variation, of course, are clearly problematic. And then there is the challenge of complexity. Implementation must reflect social context sensitive and dynamic nature of innovation adoption. We have a little understanding on the context and what make something work in one place, what are the complex elements that make something work in one place or not work in another place, or in a setting, or not even place, but virtual place also. Indeed, the complex context systems, so we know that they're not even simple, they're not complicated, they're defined as complex because they are dynamic, unpredictable, not easily disaggregated. But what about learning between systems? So implementation model like NAS. NAS is a framework model, non-adoption, abandonment, scale up, spread, sustainability framework, to give you exactly the acronym. Look at the general process. So NAS indeed framework developed the study unfolding technology programs in real time, and in particular to identify and manage their emergent uncertainties and interdependencies. Is a framework that could be applied across a range of technological innovations in health and social care. And there are several potential uses to inform the design of a new technology, to identify technological solutions that have a limited chance of achieving large-scale sustained adoption, to plan implementation, scale up, rollout of technology program, and then to explain and learn from program failure. But this framework in particular is focusing on learning within system. And it's able to highlight the broader organizational challenge within a system. The question here, what about learning between systems? That was what was the need, and is still the need at European and global level. And we know context is vital. So each health system is also a unique context. So we need ways of understanding this context and how to move between them. And there is enormous potential. Innovation is the largest challenge facing health systems. So that's exactly what TO REACH was supposed to do, and has done through his work to build a strategic research agenda, really provide conceptual framework that could be used for future activities on what should be considered when thinking about how we can learn between systems and increase the implementation. And this work was translated not only in the strategic research agenda, but in two important policy briefs that have been published in May by the European Observatory, with the contribution of different partners from the project. One on what are the key priorities areas where European health systems can learn from each other. So the question, what are the priorities we should focus on? And the second, exactly what I'm talking about. Knowing these priority areas, how we can make sure that the innovation, service and policy innovation related to these areas can be transferred between systems. So this is a conceptual framework that was developed by TO REACH. Conditions for and determinants of successes and failures for the transfer of service and policy innovations between regions and countries. You see originating systems, receiving systems, with several steps that should be taken and research questions that should be addressed to come with to really guide the process. Of course, this was an initial conceptual framework. The idea of TO REACH was to provide some general terms on what was supposed to be done in the future. And this is an agenda for future further research, because we don't have the answers yet. We know what we should focus on, so the guide to what we should focus on, and indeed the work that should be done in the next years to come. Then, of course, the policy brief on how we can transfer innovation was really, the bullet points here are summarizing what were the main elements included there. So the fact that innovation is central to health systems, so implementing technological innovation requires organizational innovation. This is a crucial point. We cannot focus only on technological innovation if we don't focus also on the organizational innovation. Implementing innovation is a major challenge for every health systems. So we cannot focus on learning only on within system. And Europe is a natural laboratory of systems we share values that would benefit from learning from each other. But I would say that, of course, this is a European action. But as I said, there is much openness for working on that at global level, because we understand the challenges are global. Then the policy brief on what areas should we direct. So what should be the key priorities? Methodology of priority used the mapping of EU and member state level policy, and not only EU, but also other countries that were participating in the project of To Reach. So we mapped these strategic documents, policy documents, sister initiatives to understand more or less what were the priorities in this field. But then we held also national roundtable meetings involving policy, actors, NGOs, industry, academia to discuss priorities. And then we conducted also an online consultation. And we came with a long list of priority areas in this field, in this mapping exercise that we grouped in these 4 major priorities: person and population centered care, integration of services across health sector and beyond health sector, and which are related to policy issues, and enablers that are enhancement of health systems functions and the reform of specific health sectors. All these areas are of course fully interconnected. In fact, looking at overarching priorities from disease-oriented and patient-centered care to person and population-centered care, we see that these require integration across all healthcare sectors and integration across traditional boundaries, social care, occupational health, prevention. And that was extremely clear during, and it is still clear during the pandemic COVID-19, and what we are living, the need really to integrate services, to work more the community care, not to avoid too many hospitalizations, to where possible. And so on. So really to rethink and redesign our health services in these regards. But this was done before the pandemic. You can see how much this is absolutely even more urgent now. The implications for the development of services, long-term care indeed needs to be developed to meet future needs. Hospitals have to develop new roles, tasks, and organizational structure. Mental health care, which is becoming extremely relevant, also considering what is being we've been living with the pandemic, needs to be reinforced. And in fact, after these recommendations really from To Reach, even the Commission even reinforced this field in the whole Horizon Europe program. And the following areas are instrumental and are all interconnected: human resources, information and communication technology, quality improvement, financing, and good governance. So again, the interconnectivities between them, between policy priorities and enablers. So what we had from this experience of this mapping exercise, what we are learning? We're learning that capturing citizens and civil society needs are really important. We need to map needs involving multiple stakeholders. We need to become we need to create regular channel of communication with them. Both responding to COVID-related needs and wider health and social care priorities. And then thanks to Reach, we were able really, as I said, to create a movement, to create a roundtable discussion that was not even happening before. And convergence or collaboration opportunity. To Reach indeed was able to put together, to synergize with different initiatives that were already happening at European level, because the implementation and learning across health and care systems provide a horizontal support to other initiatives and other fields of research, indeed, to help their insights be implemented in practice and shared across European health systems. Now I'm going to the last part of the presentation. So having said that and done that, To Reach ended indeed in May 2021. The goal was also to inform the future Horizon Europe program, because as I said, it started in 2016 and was supposed at the beginning to end in 2019. That was extended for 2 years. And there was the time in which the Horizon Europe framework program was about to be built at European level. And there was a cluster on health in the pillar 2 and priorities to be defined. And one thing about Horizon Europe, it's new approach to partnerships, in which I'm not gonna take too much time on that. I'm just saying that this is the future of To Reach will be really this co-funded partnership in which countries, on one hand, member states, associated countries, will but not only, this has also to be discussed, also depending on the participation on the different countries at international level to the Horizon Europe program. So there are agreements between the Commission and the different countries. And of course, the European Commission at the same time. So all of them are aligning their resources to a common goal. And one of the partnership in it, as you can see on the left side of the cluster health, is a transformational system that actually is called Transforming Health and Care System Partnership. It's in the light blue. As you can see in orange, they are the institutionalized partnership, the future IMI, and the global health partnership, the future DCTP. There will be a future partnership, CSA, to build the future partnership of pandemic preparedness. And then in light blue, you can see these co-funded, meaning that they are really big program in which on one hand there are countries and on the other hand there are commissions putting money to fund research and do research activities in this field. This partnership is learning from To Reach and is the first initiative that is really informing this partnership, but it's not only To Reach, it's also the Active and Assisted Living program, which is a program that is really looking at innovative solutions for the aging population. The joint program initiative, Morias That Better Lives, which is looking really at demographic change and research in actions to respond to challenges from demographic change, looking specifically on the social component. And the European Innovation Partnership on Active and Healthy Aging, which is mainly mobilizing regional and local actors, really to look at the practice. And then I see PERMED, International Consortium on Personalized Medicine, and the old personalized medicine. We had many initiatives, we had meeting with ERA PERMED, I see PERMED, really to discuss on the common synergies. But in any case, this partnership represents a fundamentally novel approach to the problem, creating synergies, bringing together elements of previous and parallel initiatives, but really aiming at creating, identifying, testing innovative solutions that can realistically tackle the challenges of health and care systems. This is the objective. The approach really will try to address the gaps in research innovation in this field, so putting more money on that, focus on the knowledge translation, making sure that the evidence can find a better challenge to reach the policy needs and the practice, focus really much on implementation. So most of the action will be really on implementation. So even actually collecting from good practices already happening and try really to implement them further, and strengthen the research innovation capacity in this field. So initiative like this one that you are organizing is exactly in that regard, or really try to reinforce the capacity and of the research innovation community. Will last 7 years. This is my last slide. Several countries from Europe, outside Europe, expressed interest in participating in the partnership. Obviously, those countries, in particular outside of Europe, that are they have already an agreement with the Commission, they're discussing already with the Commission about the participation in the Horizon Europe program more in general. There will be a call that will be launched now in October, and we will need to submit a proposal. Of course, it's not a typical proposal because it's a proposal in which only countries will participate together with the Commission. So in a way, of course, we'll follow the evaluation process, but in a way, it's actually we don't expect to have many proposals rather than only one. A core group of countries now are working to build this partnership. We worked on the first draft of the Strategic Research Innovation Agenda. Myself, I'm in the core group of these countries and I'm coordinating this core group. We came with a draft of the Strategic Research Innovation Agenda, which is learning from To Reach what I was telling to you. But of course, it's also larger. And we open an internal consultation with stakeholders at a national level interested, but also with initiatives interested in this partnership. And we expect to collect inputs and finalize the Strategic Research Innovation Agenda will be included in the proposal. And we're also talking, as I said, with different initiatives at the moment. As I said, innovative health initiatives, IC Permit, and then also the Youth for Health program, cancer plan, and also those, I forgot to add here, those working on the pandemic preparedness, because we also really think that what we are doing to respond to the COVID-19 will, I mean, at the moment there will be a very big laboratory really of much practices, or many practices that we could really use really to look at where were the gaps and challenges and what we can do better and what we can learn from the past. So we assume that all the initiatives in this regard will be definitely linked to the partnership. The actual beginning of the partnership is expected to start in January 2023. So, and we look forward to these future initiatives. At the moment, the Commission has highlighted the maximum amount of 100 million euros, and countries are also estimating 200 million euros, more or less, of investment for 7 years. So we expect a lot to happen in this field. Thank you very much.
Thank you very much, Sabrina Montant, for your very interesting presentation indeed. I will now once again invite everyone who is following us to raise their questions to one of the participants. Please use the chat on the Zoom platform that we have, and let us know to whom the question is directed to. Meanwhile, we are waiting for your questions. I would start off with a question to Paula Caffarena. I think it was very interesting because we have really stretched over several centuries with the two panelists today. Paula Caffarena has taken a perspective from history and looked at pandemics and how they were dealt with in the past, and also what can be reflected upon current pandemics based on the knowledge that we have gathered on past pandemics. So if I understood you well, you said that three key aspects to look at if we look at pandemics are the context, the multidimensionality, and the public health system. So if you compare previous periods of previous pandemics with the one that we are facing now on the global level, how do you think have specific factors remained the same, and how did they evolve in time? You mentioned very briefly that there was, for example, this divide between urban zones and more rural zones, and that there were differences, and that such kind of differences switched to different ones in the present. Perhaps you could elaborate on this, taking as an example the current COVID example.
Muchas gracias por la pregunta. Creo que es muy interesante mirar las continuidades y los cambios. Creo que uno de los elementos que permanecen cuando ocurren estas situaciones de epidemia tienen que ver con el nivel de incertidumbre y la dificultad para enfrentar las epidemias con ese nivel de incertidumbre. Creo que cuando nosotros estudiamos las epidemias en una perspectiva histórica, tenemos la capacidad de ver el inicio y el fin. Y eso tiende a mostrarnos como un panorama mucho más ordenado de lo que realmente ocurrió en ese momento. Entonces creo que hay una diferencia en el análisis que es importante rescatar, porque muchas veces desde la historia se ve que es muy claro la epidemia, que él se enfrentó así, y bueno, creo que la pandemia actual nos muestra que esos niveles de incertidumbre están siempre presentes. Ahora, también efectivamente, considerando estos factores que yo menciono, la multidimensionalidad, la importancia de los sistemas de salud pública y también los contextos, creo que algo que permanece y que tiene que ver con ese nivel de incertidumbre es la dificultad de ver cómo se encadenan estos factores diversos, la multidimensionalidad. Lo que hemos visto hoy es muchas veces, al menos lo he visto más en una discusión en América Latina, de qué va primero, lo sanitario, lo económico. Muchas veces se pone en duda determinadas medidas porque privilegian lo económico por lo sanitario. Entonces creo que esa dificultad para poder efectivamente comprender la importancia de lo multidimensional es un factor que permanece a lo largo del tiempo, porque probablemente no se trata de poner una cosa por sobre la otra, sino justamente la dificultad que muchas veces tenemos para poder que sea un engranaje, en el fondo que se concatene de la mejor manera. Creo que sin duda uno de los elementos que podemos marcar como una diferencia relevante tiene que ver con los avances científicos médicos. Por supuesto que la velocidad con la que hoy se elaboró una vacuna no la podemos comparar con lo que ocurría, ¿no es cierto?, ni siquiera durante los primeros 50 años del siglo XX. O sea, por supuesto que ese es un factor diferente que nos ha permitido ejercer un control, aunque no voy a decir total, pero sí relativo, de una enfermedad en un muy corto periodo de tiempo. Ahora, finalmente, como para sintetizar, también otro de los elementos que difieren en relación a las epidemias que yo he estudiado más en detalle, que la mayoría de ellas corresponden al siglo XIX, es la consolidación de los sistemas de salud pública. El periodo que yo he estudiado es un periodo justamente de formación de la salud pública, y las epidemias han sido una especie de motor que ha permitido que estos sistemas de salud pública se consoliden, o al menos una especie como de empuje a que los sistemas de salud pública, por ejemplo, en América Latina, se comiencen a organizar de una mejor manera. Creo que hoy, si nosotros miramos las respuestas frente al COVID-19, la situación es distinta. Tenemos sistemas de salud pública y tenemos organizaciones internacionales también que permiten al menos liderar o mostrar determinadas estrategias. Creo que ahí la tensión entre continuidad y cambio es una tensión permanente, pero que puede aportar también en el análisis.
Ok, muchas gracias. Igual quisiera hacer una pregunta a Paula. Bueno, describiste desde una perspectiva histórica también, lo diría, como cuestiones de desigualdad social, ¿no? En esa relación entre lo rural, lo urbano, luego los hacinamientos en las ciudades, etcétera. Y me gustaría saber si en tu investigación también viste el aspecto como de una, bueno, porque supongo que hubo siempre una intención del Estado de controlar la situación, ¿no? Desde que se vio como un problema general. Y me gustaría saber desde una perspectiva histórica, qué pasó con, digamos, con posturas de desconfianza y cautela de ciertos grupos hacia el Estado. Porque, bueno, actualmente, ¿no?, lo que se discute mucho, al menos aquí en Alemania, es que se supone que ciertos grupos no están tan vacunados como otros, por decir, ¿no? Y luego se supone que tiene que ver con falta o con cuestiones, digamos, incluso de analfabetismo, o digamos que no entienden el idioma o que no saben bien, ¿no? Pero yo creo que lo que muchas veces no se ve o no se toma en cuenta, que hay cierta desconfianza hacia el Estado por su experiencia histórica, ¿no? Cómo han sido tratados. Aquí serían sobre todo grupos, digamos, migrantes, ¿no? Y en América Latina quizás son grupos como por ejemplo, grupos indígenas, afrodescendientes en general, grupos socialmente minoritarizados que tienen experiencias históricas como de esterilizaciones forzadas, etcétera, ¿no? ¿Existen precedentes históricos?
Es una pregunta difícil de responder desde la historia, desde una perspectiva general, porque justamente en el caso, por ejemplo, de América Latina, la relación con el Estado tiene muchos componentes locales. ¿Por qué digo esto? Porque sobre todo a fines o durante el siglo XIX hay estados en formación en América Latina. Por lo tanto, son periodos donde existe un Estado, pero también existen muchos poderes y grupos locales que están también ayudando al Estado. Por ejemplo, la Iglesia. Y lo menciono porque, por ejemplo, en el proceso de vacunación, durante el siglo XIX, el Estado podía tener una política de vacunación y decir todos se tienen que vacunar, pero muchas veces para que esa información fuese de confianza y la gente fuera a vacunarse, era la Iglesia, y me refiero a algo muy concreto, los sacerdotes durante las misas, en sus sermones, quienes le decían a la población que se debían vacunar. Entonces, en esa lógica, creo que en estos procesos iniciales de vacunación, al menos durante todo el siglo XIX, probablemente ya a inicios del siglo XX tenemos estados más consolidados con mayores instituciones, pero durante el siglo XIX lo que vamos a ver son estas otras instituciones que colaboran también con el Estado para que estas políticas de salud funcionen, o al menos se puedan difundir. Ahora, creo que lo que mencionas respecto a esta relación entre el Estado y cierta desconfianza, sí, uno podría rastrearlo y podría mirarlo desde una perspectiva histórica también durante el siglo XX, y de aquellos grupos que han estado más marginados, y que hay una mayor desconfianza hacia las políticas que va planteando el Estado. Creo que en el caso también de América Latina hay un factor socioeconómico. En general, aquellos grupos más pobres son los que han tenido menos acceso a beneficios del Estado o a estas mismas políticas. Estoy pensando sobre todo a inicios del siglo XX, donde se desarrolla el problema de la cuestión social, son aquellos que viven en condiciones de hacinamiento, y los estados en América Latina se van a demorar. Estoy hablando hasta los años 50, 60, en generar políticas que efectivamente sean universales. Hay hartos factores. Después la discusión en torno a si las vacunas debían ser obligatorias o no. Y ahí también aparecen otros temores respecto a o discusiones en torno a la libertad individual versus la libertad colectiva. Creo que son varias aristas, pero sí hay un denominador común en torno a que el Estado sí ha necesitado de otras instituciones para poder llegar a una población desde una perspectiva más global.
Gracias.
Thank you very much, Paula. Sabrina, we have also, of course, questions to you. Thank you very much again for your presentation. I mean, there are so many topics on which we could talk about. I was just starting to think, of course, your project started before the pandemic, so you haven't been at all like thinking about what would happen amidst your project. But even so, I guess you have had a good insight based on your consultations and research on what was going on in all over Europe. And my question would be, which factors, based on your ongoing project and research, would have helped a lot if they were already in place in the health systems in order to better address the pandemic, to be better equipped to address the pandemic? What do you think would have been really important factors that could have already been in place?
Well, the question is difficult. And I think that there is not one answer, because there is not one fact only. First of all, we need to, well, if we look at the European perspective, we were really late in coordinating our response to the pandemic. We know that. And we do know that the partnership on this field and more public health common research in Europe perhaps would help to have also quicker channel of exchange of data, practices, really, I mean, infrastructure also, I would say. Everything, I mean, it was especially, I mean, in the European experience, we saw that the European Commission had really to stretch their own, their competencies really to respond to the challenge, to coordinate the efforts in even organizing the purchasing of the vaccine, in the equipment, in responding, even in the exchange of human resources at some point. During the first wave, in particular, you remember, it was, you know, doctors traveling across, and even in now there is actually I mean process in different member states, or procedures in different member states, in which immediately hospitals get organized when there is a certain level of contagious across the country, so they know that a certain percentage of the beds have to go to COVID-19 patients, and this of course reduce the beds for other patients, but on the other hand, these patients are, those patients of other diseases feel neglected, we know, and they don't necessarily, they need to wait long time, and again, perhaps some there have been projects funded and research done in Europe. We don't have to say that there was not in the past. There were in the past projects on integrated care, on how to reinforce the primary care, but perhaps are fragmented, and more. We need more. We need to learn also from outside of Europe. We need to make sure that we have a common framework, I would say. This is what was missing. And in fact, I will end by saying that when the pandemic started, we were right in the middle of the discussion on this proposal, on this partnership. At that time, was not even sure that the partnership was gonna be part of Horizon Europe. I mean, the work up to REACH was really supported, so we had really support of different stakeholders and countries. But I have to say that many countries were not even understanding why we needed that and what we were talking about when we were talking about evidence-enhanced systems. Now the pandemic did one good thing, really reveal things that we were saying before, which is not good, of course, because that was really, you know, the consequence of a lot of, you know, suffer. But I have to say that in reality now it's clear, it's more clear, and we're moving towards that direction. So hopefully. We don't want to have a future pandemic, but for future pandemic will happen, we might be more prepared. Who knows?
Thank you very much. We have also a question in the chat, and I wanted to combine this question with also a thought that I had, because what we have seen in many countries, both in Latin America and in Europe over the past, let's say, 3 decades, is that there was a tendency to really save resources in the public health sector by large. And I was also wondering how this, for example, had an impact on dealing with the pandemic. And you also mentioned, Sabrina, that that innovation was the largest challenge that you found out to be the largest challenge. And I was wondering how this tendency to really save money wherever you can in this public health sector also really puts a difficulty to innovating in the sector. And we have here a question which is actually directed to Paula Caffarena, but I would say that both of you can have a say on it. I will read it in Spanish because this is the language in which it was written. Podría preguntarle a la doctora Caffarena qué conflictos sociopolíticos, por ejemplo, territoriales, lucha de clases, neoliberalismo y derechos humanos, estarían atravesando y afectando las negociaciones por la implementación de tecnologías biomédicas en las formaciones estatales latinoamericanas actuales.
No sé si es una pregunta que yo puedo responder desde la historia, porque justamente apunta más bien a un proceso actual, pero solo mencionar un par de cosas. Creo que cuando yo me refiero a los procesos de formación del Estado, me estoy justamente refiriendo a un proceso de formación estatal del siglo XIX, cuando en América Latina pasamos de ser colonias a república, y eso implicó que había que formar un Estado y las naciones, y es un proceso único en ese sentido que es bien relevante y donde uno puede ver una especie de mixtura, una mezcla bien importante entre cómo estos estados que se están formando tienen que además hacer frente a problemas sanitarios. Y en esa medida los problemas sanitarios parecieron como ayudar también a esta organización estatal. Entonces yo creo que ahí hay un proceso, ese proceso es muy propio del siglo XIX. Ahora, de todas maneras, creo que efectivamente hay conflictos de carácter sociopolítico que afectan la implementación, por ejemplo, de la vacunación, y hay un tema territorial que es relevante y que ahí sí creo que es importante cómo los estados llegan o la capacidad que tienen de llegar a los diferentes territorios en sus propios países. Y sin duda en América Latina hay no sé si la palabra correcta es problema, pero sí hay una situación relevante en términos de cómo el Estado llega a los diferentes territorios que lo componen, ¿no es cierto? El Estado no es igual en las capitales a que en diferentes regiones o incluso en zonas rurales. Yo creo que ahí hay un desafío importante de cómo el Estado finalmente es un Estado que está presente en todos los rincones del territorio. Creo que también hay una situación que es importante y que tiene que ver con algo que mencioné muy rápidamente en la ponencia en función de la universalidad de la vacunación versus la distribución de vacunas de hoy, ¿no es cierto? Que tiene que ver con que cada país finalmente o ha podido, al menos en el caso de América Latina, adquirir cierta cantidad de vacunas, ¿no es cierto? Y en función de eso se distribuyen. Entonces, como una especie, entre comillas, de mercado de vacunas que se van adquiriendo y eso también va generando desigualdad en el acceso. ¿Sí? En el caso de Chile, que ha tenido la posibilidad de tener un gran número de vacunas, yo comentaba al inicio que ahora van a partir vacunando niños en el país, difiere enormemente con el acceso y la disponibilidad de vacunas que hay en otros países. Entonces creo que sí hay conflictos o situaciones sociopolíticas muy vinculadas a la implementación, por ejemplo, de la vacunación, y que ahí tienen un poco o se contraponen o hay una tensión con este principio de la universalidad de la vacunación que aparecía tan claramente en aquellos médicos o pensadores, por ejemplo, que yo he revisado durante el siglo XVIII. Eso creo que puedo aportar desde mi área del conocimiento. Quizás Sabrina puede profundizar más en temas actuales.
Can you hear me? Well, I think that It is difficult to say. I mean, it's a really difficult question. Really, I don't know much about the situation in Latin America. What I can say is that the challenge faced by the implementation of technologies that we look at in the TO REACH project, at least we're really focusing on the challenge faced by organizational and innovation. The fact that you can cut the resources, but you need to still, you can cut, but only if you have introduced innovation and change in the organization setting, because there are certain elements that can, when we talk about resilience of health and care systems, that have to be there. Well-trained health workforce. We saw that was a big issue during the pandemic, and is still a big issue, the lack of health workforce. That was something that in Europe we were studying very much before, because that was the big problem. Now, clear problem where we didn't have enough workforce there, and not necessarily all trained for the challenges that are faced, and not all equally across the different countries. Infrastructures. These are things that have to be reconsidered. So I think that at some point we need to be, how can I say, very courageous in the future. I hope we will be in the future partnership and really come with some clear research questions on budgetary mechanism, on how really which one should prevail, and really put an emphasis on fiscal constraints as well. These are questions that we need to address. And how to include health values in a reimbursement system. So all of these are research questions. At least we look at these challenges from a research perspective. Let me say that. So we're not responding. We're not as policymaker. What we know is that perhaps the research failed sometimes in providing clear answer to the policy actor, and that was also that sometimes legitimated policy actors not to follow evidence. So we shouldn't give this. We shouldn't. I mean, make sure that the answer are provided, they're understandable, they're immediately implementable. Or immediate, at least they are implementable, and that's exactly the point. So really answer to questions that respond to needs, to policy needs. So setting this research question, thinking about the policy needs, really which answer we need to provide, indeed. So I don't know if I answered to that question. That was really challenging one.
Definitely, yes. Thank you very much. I also would add that not only researchers need to really focus on what is in this moment needed, but they also need really effective communication channels, right? Yes. With the policymakers. Otherwise, they are just on two parallel paths, basically. I think many people have learned a lot through the pandemic. It is sad, but it is also important.
The risk this is that is lost, you know, if we don't. I mean, you learn, but then it's fragmented, and then it's not translated into effective future policy and practice. In fact,
right.
And that's why we want to push for this to happen. We'll see.
Yes, thank you very much. We are almost coming to the end of our time, but I will just ask you a short question, Sabrina Montant. You mentioned that there will be a call launched in November for the next phase, October, for the next phase of your project. So my question would be, but because I think that some of our audience would be also interested in who can exactly participate in this call. Is it European partners? Is it also Latin American, Caribbean partners? And which kind of partners are you looking for?
Okay, this is a very good question. At the moment, as I said, the partnership will be, the call is to set a partnership, okay? Which a partnership is like a program, a big funding program, co-funded by countries and the Commission. So we need those that allocate money, you know, to be very, very frank with you. But not only, because I think that definitely the grant signatories will be funding institutions. In Italy, for example, is the Ministry of Health. In other countries, it's not the ministry that is holding the money. There are agency funding. But the idea is also to, the partnership will be organized through pillars. I haven't presented that because it's a work in progress. It's not there yet. So there are also information that are not validated yet. But we know that most likely they will be organized in pillar, and in the there will be pillars in which we will need to do some, put in place some methodologies to identify priorities, constantly assess these priorities. So we assume that these funding institutions will get the support also of experts, key experts at national level. And that will be done, we need to see if they will be involved in the consortium, they will be involved through advisory board, they will be done through the funding. So we're gonna allocate funding, collect projects to provide answers. So this is an answer that I don't have yet. Definitely funding bodies, could be some in-kind activities done by some research organizations inside the partnership, a little, because we don't have much money to co-fund that, you see. So we also have to be careful with the money we have. And last but not least, ministries. We are going to set a policy board in which not only Ministry of Health, but also Ministry of Research, and perhaps even Ministry of Economic can be involved. Because if we talk about budgetary mechanism, we provide some useful insights on that. It will be interesting to discuss it with a policy board that is not only involved in the Ministry of Health, which many times have really little to say at the country level on money allocation, you see, to be very frank once again with you. So that's we need really to have a structure in which we try to reach the best outcome out of based on the, I need to say as a last thing that we need to follow also the European rules set by the European Commission. So we cannot have a too large consortium. We assume that many stakeholders will be involved through the funding. Important is that if your country is not participating, allocating money, institutions from that country cannot be beneficiaries of that call. So that's the thing. So important to check if the countries have an agreement with the Commission, if they're outside of Europe, to work on Horizon Europe, and if they're interested in participating in these initiatives in Horizon Europe. I hope I was clear enough, but I'm sure the Commission can also further explain.
Perfecto. Thank you very much for the two of you for taking your time and to giving this really interesting inputs. I think it is a lot of food for thought, and it was a good, I think, final part of the series. I don't know what you think, Gilberto, which really tried to look at the theme of the pandemic and how we could find ways towards a resilient recovery from this pandemic, from different perspectives. I think it was a very, very good final session. Please, Gilberto, you can also say something.
Yes, thanks a lot. I liked it a lot. And I also think that it was a good final session because it also englobed like several of the dimensions that were present in other presentations and other talks. So it was, yeah, like a great conclusion in the end.
Thank you very much.
Thank you to both of you.
I also would like to thank our interpreter, Stefanie Teixeira, and I also would like to all the attendees, not only the ones who are following us directly in the Zoom platform, but also the many more attendees who look at Facebook Live currently or in a few moments or in a few days. This Keynote Lecture Series has raised a lot of interest, and this is really something that is that is showing that the topics and the experts we invited was really relevant to many people, both in Latin America, the Caribbean, and Europe. And we would also like to let you know that based on those keynote lectures, the Program for Latin American Studies and the EU-LAC Foundation will elaborate a small compilation which will reflect all of the inputs of the keynote lecturers, and we try to finish it in the upcoming weeks, and we will also translate it in both languages, in Spanish and into English, and it will be available on our websites. If you have inscribed in the Zoom platform, you will also receive it afterwards. And we will also share with you a small questionnaire in order to evaluate this keynote lecture series. So please do not hesitate to get into contact with us, to give us your feedback, and to also support us in disseminating the results of this series. We will also make available all the videos recorded of the lectures via YouTube. So anyone who cannot follow us today, but who wants to see one of the videos later, he or she will be invited to do so. We hope it was of interest for you, and thank you very much for attending, and to you experts to having us with you.
Thank you very much.
Muchas gracias por la invitación.
Adiós.
Gracias.
A ustedes.